Good afternoon, ladies and gentlemen, dear colleagues. I am Marc Coppens. I am anesthesiologist in the University Hospital of Ghent, and I'm the president of the Belgian Association Ambulatory Surgery. Today I will tell you about the implementation of a digital patient platform in our ambulatory surgery unit. Day hospitals have a case mix of many minor operations with an increase in more complex surgical procedures. And as you know, the workaround time is very limited. Ambulatory care aims at guaranteeing the continuity of care postoperatively, and therefore we need some kind of follow-up of the patient. We wanted to optimize the patient's ambulatory pathway and search for digital tools to assist various caretakers to follow the patient along a continuum from the preoperative period to time of discharge, including the early and late postoperative recovery. Digital patient platforms may impact clinical outcome and health delivery service through different mechanisms. They aim at improving patient participation and patient empowerment to ultimately contribute to patient satisfaction and better therapy compliance. The primary goal of the study we performed was to identify barriers and facilitating conditions for successful implementation of a digital patient platform. We used an existing platform called COSO, which is Dutch for Collaborative Care Platform, whose mission is to be a digital healthcare cooperation platform connecting patients and caretakers that allows quick and safe exchange of medical information multidisciplinary. The first care pathway within the digital patient platform within COSO was developed in the oncology department. Later we included care pathways in orthopedics, ear, nose, throat, and other medical disciplines. Originally, it was only accessible on computer, but a mobile application was launched in 2018 and it became possible to send push messages. We started with a limited number of clinical care pathways in a stepwise approach. First, arthroscopic knee surgery, including the anterior cruciate ligament reconstruction. And we compared outpatients with inpatients. We choose for orthopedics as we hoped to reach young, healthy people who have access to digital tools and feel confident in the use of computer, mobile phone, and are willing to explore personal health information on the digital platform. We also included ENT patients undergoing sinus operations and hospitalized patients, which allowed us to compare COSO with commercially available apps like My Sinus Coach. This is the COSO start screen, which is obtained after the patient has registered with electronic ID and PIN code. The screen indicates patient demographics, informed consent to share information with different healthcare workers. At the right, you can see the different hospitals where the patient has consulted previously and are willing to share information. And then at the bottom, several options for the patient. He or she can see results of laboratory investigations or radiologic images. He can make online appointments and he can consult specific care pathways, including specific surgical care pathways in ambulatory surgery. Secure messaging enables the patient to exchange non-urgent health-related information with a team member responding to incoming messages. This is an example of a care pathway for knee arthroscopy, providing practical information preoperatively. information on preoperative tests, the possibility of having a preoperative anesthetic consultation. The patient platform includes an informative part with visualization of the individualized care path. Different steps can be chosen for each patient, which makes the pathway customized. Provision of reliable information about the diagnosis and the treatment, links to relevant websites, contact details of the treatment team, and an active part with the possibility to have secure conversations with the treatment team, self-registration of complaints and other problems in diaries and other questionnaires, and a question prompt list. We used a mixed method approach to get insight in problems related to implementation and use of our digital patient platform with quantitative analysis of log data to know how many, how often, and what specific items were used by the patient. We held interviews both with patients and all kinds of healthcare providers. We offered validated questionnaires to patients to evaluate more specifically patient satisfaction with the digital platform. The goal was to know why or why not the platform was used and recognize use pattern of a typical patient in ambulatory surgery. We screened 555 patients. 140 were not included for organizational issues. The OR scheduler didn't have time, completely forgot the study. 415 patients were asked consent, but 189 of them failed to get access for different reasons. The recruiting nurse didn't have enough time because of a high workload. The patient wasn't physically present when the appointment for surgery was made, and so on. Some of the patients lost interest after all. And the most difficult part, they didn't have an eID reader for secure access. 226 patients achieved to get access, but some of them got overwhelmed, forgot the whole thing, lost interest, didn't feel the need for additional information, and were not convinced about the added value. So, did we have the right target population, as ambulatory care is only characterized by a brief contact with the hospital? Only 22% of patients actually registered on the digital platform, and many of them without making further use of the system. 60% of participants made use of the platform between 1 and 4 times. There is a difference in the frequency of use between knee surgery patients and ENT. Knee patients use the platform 50% less frequent than ENT patients. The platform was used 82 times preoperatively and 70 times postoperatively. When did patients use the platform? Well, most often it was used between 12 days before and 14 days after the procedure. The day before operation was the day with the highest participation rate. A reminder email was sent the day before the operation. What can explain the peak? Coupling of the patient's email was essential, and for legal and GDPR reasons, the patient had to do this himself. Patients that coupled their email address were 1.4 times more likely to use the platform. Not amazing, of course. Analysis of log data confirmed that ENT patients used the platform more often. There were no significant differences in the use of COSO according to age or gender, or between inpatients versus outpatients. When the mobile app became available, it was used in 36% of patients. We received 321 different questionnaires or diaries. Only 9 conversations took place. Only half of the patients filled in their email address. These patients more frequently used the tool. We couldn't find real predictors for not using the digital platform, as having a smartphone, differences in social status, the amount of worrying post-operative, The need for contacting the surgeon, lack of pain medication, or level of experience with technology. This could be caused by the fact that the OR schedulers and nurses kept giving the information on paper as well, although we insisted not to do this. The users, after all, were quite satisfied with user friendliness, usability, user conditions with scores between 3 and 4 on a scale between 1 and 5. This was an eye-opener. A post-operative questionnaire revealed that 23% of patients were worried about post-operative pain or recovery. 28% contacted the hospital or GP, and as many as 20% returned to hospital or visited the general practitioner. 11% had insufficient pain relief. We can only hope that these figures are biased by the fact that only patients with worse outcome would have used the platform, while those with better outcome didn't seek help or additional information, and for that reason were less interested. Although, of course, we would have liked to hear from good outcome as well. We held semi-structured interviews with different users of the platform: OR schedulers, surgeons, IT specialists, and patients. Barriers for successful implementation of our digital platform were a lack of user friendliness, at least for the OR scheduler who had to start the pathway for a particular patient, concerns about liability in case of breached privacy or harmful patient behavior, or liability when failing to respond in a timely way to patient inquiries or red flags like high pain scores. Lack of added value for all involved parties was a barrier. Increased workload and disruption of workflow were feared. There was concern among providers that they did not possess the skills and capacities to deal with technical problems and requirements if patients experienced problems to get into the system for answering questionnaires, for instance. Some providers were reluctant to give up autonomy, a consequence of giving patients control over activities traditionally arranged by the providers themselves, such as booking appointments. User friendliness, follow-up possibility, and the remote monitoring were perceived as facilitator. The robust authentication process reassured both patients and providers. The introduction of the mobile app was an advantage for patients. Data exchange with electronic health record of the hospital is yet not possible, and a barrier for ease of consultation of preoperative questionnaires, for instance. Direct communication from the digital patient platform of postoperative validated scoring systems could result in less time-consuming postoperative checkup or even reduce the need for postoperative consultations. OR schedulers played a crucial role in the implementation of the portal, but were especially concerned about the increased workload. They felt incapable of giving enough information to the patient on the content of the digital platform, the accessibility, the completeness of information, and the stability of the system itself. Moreover, as it was a clinical study, they had to inform the patient about both the platform and the study as well. Although the OR schedulers had the continuous support of our study nurse, they felt that this was not enough and not sustainable on the long term, and were convinced that it was the responsibility of an advanced nurse practitioner to assist the patient throughout the whole perioperative period. It is not clear if this is affordable in a business case, as financial incentives are either unexisting or too low. Financial remuneration is actually too low or non-existing. Moreover, there are no documented cost savings from using patient portals. Cost savings could be quicker and more efficient postoperative consultation and checkups. Patients using the tool feel more engaged with care, feel more in control of decision making concerning their health. They feel empowered to ask questions, so the overall feeling of safety is increased. These are well-motivated patients, technically skilled to access and use the digital tool. Non-users give up prematurely, not being able to overcome technical problems. They argue that a digital patient platform should augment and not replace human touch and prefer personal conversation real life. Compelling value proposition is needed to convince these patients. So we must conclude on low participation rate for several reasons. COSO performs good on sharing information between healthcare workers, hospitals, and patients. The release of a mobile app, the introduction of reminder mails positively influenced the frequency of use, and overall easy and secure access is necessary. Essential in adoption of a digital patient platform is to search for the needs of a particular patient group. Patients seem to be more interested in preoperative information, while doctors are more interested in the postoperative course. A digital patient portal should write directly in the electronic patient record. The management, and ideally the government, should stimulate and support digitalization. For successful implementation of a digital patient platform, it is important to consult different stakeholders before implementation and reach consensus about the need for the system. A competent IT project leader and team are necessary. The system itself has to be user-friendly and intuitive, needing little training. A complete management team, starting with preoperative anesthesia consultation, surgeon, and the ambulatory care unit personnel, should encourage patients throughout the entire pathway. Ideally, the case manager is assigned for postoperative follow-up. These are some references we used for in the study and in this presentation, and I thank you for your attention.